Welcome to AETCM, the Emergency Medicine channel. Today we'll be discussing about an elderly male who came to you with complaints of acute onset of bilateral lower limb weakness. So a 74-year-old male presented to here with complaints of acute onset of bilateral lower limb weakness since
So before going to the case, you tell the differential diagnosis or acute bilateral lower limb weakness.
acute one could be secondary to trauma,
Okay, main thing
spinal
is
injury,
trauma,
spinal
spinal cord injury.
then maybe some
Epidural abscess in the
Epidural abscess as such will not produce acute trauma. Epidural bleeding into epidural space can produce acute weakness. That other one abscess produces little time, 1 or 2 days. Okay.
transverse myelitis,
Transverse myelitis.
infections itself.
Okay. Infections.
Any local thrombi, any arterial occlusion,
Anterior spinal artery
spinal
thrombosis.
artery occlusion.
Then
any tumors impinging on the
tumors as such again will not produce bleed into a tumor. Okay, so all these things are very important. Okay, then
GBS,
G.
GBS is a ascending paralysis. It also takes some time. Leriche syndrome, what is that? Leriche syndrome. It is a
bilateral lower limb weakness with impotence.
okay. So where is a lesion? It is in the aorta. Okay, at the bifurcation. Okay, so that rarely can produce. Okay, okay. So these are the causes we should remember and we should treat the patient.
So this patient is a 74-year-old male. He came to here with complaints of acute onset of bilateral lower limb weakness. The previous day around 5:30 p.m. With some decrease of sensation also on both lower limbs and also some around the lower abdomen also, below the level of umbilicus. So he came to here the next day morning. So initial 10 second assessment was conscious, orient obeying to my commands. Primary survey, his airway was patent. There was no signs of any airway obstruction. C-spine was also normal. He was able to move his neck and all that. There was no complaints of any pain or anything. Breathing, he had a respiratory rate of 18 per minute and maintaining saturation of 98% in room air. On auscultation, he had a clear chest with bilateral equal air entry. Circulatory part, his respiratory heart rate was 88 per minute and blood pressure was 120/70. Disability part, he had a full score of GCS and pupils were equally reactive. And exposure.
In a paraplegia case like this, paraplegia, what is the importance of breathing? What is the importance of BP?
One thing is, if it's an ascending like paraplegia, we have to think about like it involving the respiratory muscles, and the patient can go into like an impaired respiratory failure.
Okay.
Like that.
Okay.
So initially the patient can show some mild symptoms like maybe some tachypnea or something. Then it can again go into bradypnea and respiratory failure.
Okay. So the weakness of the thoracic area can be due to
ascending
type of
paralysis.
Okay. Then.
So in blood pressure again, like maybe some autonomic involvement can happen. Then it can cause like highly varying hyper or hypotension and hypo. This thing,
So both thoracic lesions or ascending paralysis like GBS, you can have autonomic dysfunction. Okay.
So this kind of patients actually we have to watch out for any worsening of symptoms involving the respiratory involvement. So we can actually go for like a single breath count or something in initial arrival itself. So we can follow up later on.
Okay. What is single breath count? How do you assess single breath count?
Basically, you ask the patient to take a deep breath, and then he has to keep counting 1, 2, 3. So until how much ever he's able to count till he in one breath is called a single breath count.
Okay.
So one value won't have any significance.
Correct.
Single breath counting has to be done in any
so
decrease.
suppose you are the duty doctor now. You document single breath count is 20. Next time when she comes, she'll document it as 17 means it is deteriorating. Okay, so that is important. It's only for serial documentation. Serial values will give you the prognosis of the patient. Single breath count will not give any value because you may count 20, I may count 17. So that doesn't mean anything. Okay.
So this patient primary survey was within normal limits. Airway breathing circulation maintaining disability is also okay. And exposure part, he was febrile and GRBS was 115 milligram per deciliter. And primary adjuncts
type of weakness which is associated with fever, paraplegia with fever. Transverse myelitis will have fever.
Fever.
GBS come after fever.
After fever.
TB with spinal cord lesions will have fever.
Fever.
Okay,
Fever
so
with.
all these things are infectious diseases itself. Different types of presentation can be there, but most of the transverse myelitis can have fever during that episode. Okay, whereas GBS fever history can be there, may or may not be there.
So went to the secondary survey. In the primary adjuncts, we only took a GRB which was 150 milligram per deciliter. The secondary survey, the history was like the patient developed an acute onset of bilateral lower limb weakness associated with some decreased sensation from the level of umbilicus in the lower abdomen to the tip of the legs. And he also complained of some vague abdominal discomfort and also urinary retention, like some like a feeling of like not completely able to avoid urine.
So,
So
sensory level in a patient who is having paraplegia, what does it mean?
That the lesion is
2 or 3 column above the.
Lesion is in the spinal cord. It is in the spinal cord. Suppose there is no sensory level, you have only weakness. There is no bowel bladder involvement. Where all the lesion can be? You have a patient who is having acute onset of paraplegia. There is no sensory level, there is no bladder involvement. Where the lesion can be?
It could be also peripheral involvement also.
It's like GBS. Okay, GBS can have that picture. Anything else?
Peripheral nerve involvement, like
GBS.
GBS.
That means anterior horn cells are involved. In unpaired anterior cerebral artery thrombosis, how do they present? Acute thrombosis of like stroke. Acute thrombosis in unpaired anterior cerebral artery.
So one will be, if it is unpaired,
they present with paraplegia. They present with paraplegia. There is no sensory loss. There is no bladder involvement. But it is rare because most of the time we have paired anterior cerebral artery. So even if there is a thrombus, other part will correct it. Okay. So it's a very rare phenomenon. Unpaired anterior cerebral artery thrombosis. You don't get sensory level. But here in transverse myelitis or anterior cerebral artery thrombosis, you get a sensory level. Okay.
So history was like this, and there was some complaints of abdominal discomfort and urinary retention was also there, but there was no history of any fall, trauma, no history of fever, no headache, vomiting, also no history of any back pain or any visual disturbance or anything. There's no history of
back pain is classically seen in which type of paraplegia?
pot spine.
Port spine.
Pot spine is there. Then acute paraplegia like this.
Trauma.
One is trauma.
Then spinal artery thrombosis.
Spinal artery thrombosis normally they will not have pain.
Bone meds, that osteoporosis.
Okay, bone meds and all these things. Then
Pathological
transverse
fracture.
myelitis present with severe back pain. Transverse myelitis is one condition that can present with back pain. Okay, that doesn't mean that all transverse myelitis will have pain, but classical presentation is painful paraplegia with sensory level.
So there was no history of fever, trauma, headache, nothing was there, and also there was no complaint of any facial asymmetry, any vertigo, tinnitus, or any hearing loss. So the issue was more focused on the lower limbs and also with some sensory involvement.
Okay.
Otherwise, the history.
There is a facial asymmetry. What do you suspect? You have paraplegia with facial asymmetry. Where
then we have to think about some central involvement, like stroke, CV.
What is multiple sclerosis? How do they present?
Patchy involvement, like
multiple lesions in multiple area in the multiple time. That is multiple sclerosis. So you have two types of lesion which you are not able to explain at all. Then it has to be multiple sclerosis. Okay. So normally paraplegia is in the spinal cord below the cervical area. Facial nerve is in the pons. Okay. So two lesions we cannot put there. If there are two lesions, then it has to be multiple sclerosis.
So history-wise, he doesn't have any non-drug allergies or anything. He is taking medications for hypertension, dyslipidemia, and coronary artery disease, but is not a non-diabetic. Okay. Previously, he had a history of CA stomach, and for which he underwent subtotal gastrectomy about a few years back. And also he had a history of an old abdominal aortic aneurysm, but the maximum caliber that they recorded was 3.5 centimeter.
Okay. In a patient who is having CA stomach past, what are the differential diagnoses you suspect at this point?
It could be like a secondary METS, like
it can be a METS.
Imaging on the spinal cord.
Then other than that,
then Paraneoplastic syndrome.
Paraneoplastic syndrome. So two things: direct mets to the spinal cord and paraneoplastic syndrome. Okay.
And also a history of an abdominal aortic aneurysm with a maximum caliber of 3.5 centimeter. It was conservatively managed at that time.
Okay.
So
in aortic aneurysm, Zarishi syndrome is very important differential diagnosis. Okay. If there is a aortic aneurysm like that in the past and it's ongoing, then Lerishi syndrome comes as a close differential diagnosis. Okay.
And last meal was about 6 hours coming to the hospital, and there was no significant like any recent events contributing to the current symptoms. There was no trauma or anything. So clinical examination, higher mental functions were normal. He was conscious or ignoring to make amends. And systemic examination, his other systems were within normal limits. Like chest, he had equal RNAs, cardiac was normal. Abdomen was soft and non-tender, but he was not complaining of some loss of sensation below the level of umbilicus.
Below the level of umbilicus, what is the level?
T10.
T10. Umbilicus is T10. So where will be the
lesion will be like 3 to 4 above.
3 levels?
7 above.
Above. That means T7.
T7
or T6.
T7 or T6. So we went to the motor examination. Bulk was actually normal in both upper limb and lower limb. Tone, both upper limb was normal, but there was hypertonia on both lower limb. Power wise, there was actually 0/5 on both lower limb, but upper limb both all were 5/5. Then coming to the reflexes, biceps, triceps, and supinator reflex were present, but there was absent knee angle reflexes. And also decreased pain sensation, temperature, and touch was present below the level of umbilicus. There was a loss of pain, temperature, and touch below the level of umbilicus.
Have you tested vibration sense? Is it present or not?
Vibration was absent. But
absent means that is also lost. Okay. Suppose vibration sense is present, then what is your differential diagnosis?
Basically, dorsal column is intact.
Okay. So where is the lesion?
Lesion should be in the
anterior spinal artery. Okay. So that is the clue. Okay. If the posterior column sensations are preserved in a patient who is having a sensory level, then it is in the anterior spinal artery, thrombosis. Okay. Otherwise, complete transection of the spinal cord.
Okay. Cerebral signs are also.
So vibration is a very important investigation in emergency room in this type of cases. Okay.
There was no signs of any meningeal irritation, stiffness, nothing was present, and cerebral signs were also absent. So diagnostic investigations as routine.
How did you do cerebral signs in this?
Finger nose test.
So only the.
You want to heel sheen? Is it important? When you are getting a sensory level like this, you should. It's okay that you are done.
Completion sake
you are done. Okay.
So diagnostic investigations we are sent for routine blood investigations like CBC, CRP, and all that. Along with that, we went ahead with the MRI lumbosacral spine with the whole spine screening.
So what is your differential diagnosis with all these things?
So at this point, actually, we are suspecting more like a transverse myelitis because
the most important DD is transverse myelitis.
Because there is involvement of both the motor and sensory system.
Okay.
And there was no like any previous any factors. Acute onset.
Second DDs?
Second would be like
any pod spine.
Okay. Spine lesion. Spine lesion compressing
like
the spinal cord.
any malignancy, because I already had a history of malignancy, so any secondary tumor we had to rule out.
Okay.
And also any viral infections we had to rule out.
Again, viral infection producing transverse myelitis. Okay.
Also,
anterior spinal artery you don't suspect at all?
It could also be like a suspicion.
If it is not transverse myelitis, it has to be
anterior spinal
artery thrombosis. Okay, because we know how we all do vibration sense and how the patient perceive that vibration. Most of the time, patient will be in a tension situation. They may not notice what we are testing on. So it will be very difficult to assess the vibration sense in this type of patient, but it is very important. Okay, so that is the closest DD. Okay.
And also multiple sclerosis can also be like kept as a DD with only spine involvement.
Okay.
So after admission, actually our plan was to go for an imaging of the spine to rule out any physical any lesions where they present or not. And also in that we went with the MRI also lumbar spine with whole spine screening. So the initial report was showing only some posterior disc bulge in the C3, C4, C5, C6, C6, C7, and also in the T10 and T11 areas. But there was no actually impinging, none of those lesions were impinging on the spinal cord to produce any actual deficit. So otherwise the report was within normal limits.
So spine is normal.
Spine is
but
normal.
Patient is having
Weakness.
features of
Both paraplegia
and
sensory loss.
So what do you think?
Then it could be like secondary to some ischemia.
Ischemia of what?
Spinal.
Ischemia? Then it has to be anterior
Spinal cord artery thrombosis.
Okay. And if the patient recovers very fast, then we have to confirm our diagnosis because autolysis of the thrombus can occur in our body. Okay. So we are not seeing anything in the MRI, and it has to be in the anterior spinal artery. Okay.
So evaluation part, we went with an MRI. It was initially was not showing anything, and the second thing we went with the LP.
Okay.
LP was also within normal limits only.
So what do you get in transverse myelitis LP?
LP
Increased protein.
increased proteins.
Increased proteins. Sugar?
Sugar will be within normal.
Cells?
Inflammatory cells could be like
Cells are normal. Sugar is normal. Only proteins are
Protein will be-
elevated. It's like GBS only. Proteins are elevated, cells are not elevated. Okay, again, albuminocytological dissociation, but classically explained in GBS.
GPS. So MR was the normal limits, LP was normal.
What are the conditions you get only protein elevation in CSF?
Why?
Conditions. One is this
Multiple myelin.
multiple sclerosis. One is transverse myelitis, GBS,
GBS.
hypothyroidism. Okay. All these conditions you get elevated proteins. Wherever there is inflammation, there is no infection, you get only elevation
Only
of
elevation proteins. So this patient.
But we classically learn it is in GBS only.
Okay. So initial management.
So can you tell how did you go ahead with the LP in this patient? Is it very simple? Sir, you can.
No, yes. You can
tell.
Did you do yourself LP or
No.
Especially since there will be loss of the bilateral tone, and in LP the major idea is main key thing is positioning. So universal flexion position has to be maintained in order to open up the interventral that IV spaces, disc spaces. But if the patient has paraplegia, it will be hard to do the universal flexion. So we will require assistance to help him with it.
paraplegia, he himself cannot able to move.
Someone have to
But
manually like flex
limbs
the.
are paralyzed. So anybody can do it passively. Okay, only spastic means it will be difficult. Okay.
So someone has to manually flex the joint to like keep the space
We
open.
require assistance to do.
Or else if BP and other things are vitals are stable, we can make the patient in sitting position also.
It is the safest question for this patient. Bending this patient will be dangerous. But nowadays we do MRI and we rule out spinal cord lesions and bone lesions. But previous days we never used to make the patient bend because that time MRI and all were not there. So sitting posture is one of the safest practice for this type
This
of
kind of
patient.
condition.
Correct.
Any unconfirmed diagnosis, doubtful, better sitting position. Okay.
So evaluation part. So initial blood reports within normal limits, some mild elevation CRP. That's all. MRI was within normal limits. LP was done again normal. So considering the patient's clinical symptoms, we initiated him on a high dose methylprednisolone, and also heparin was also initiated. And along with that, there was no clinical improvement as such. So we sent for some antibodies like CSF for neuromyelitis optica, but even though there was no optical involvement, which again came to be negative. And also we were sent for multiple sclerosis workup. That again came to be negative. So with the initial management of this thing, steroids and heparin, the patient's slight improvement was only 2/5 power in left lower limb.
What is this blood supply of spinal cord? How do spinal cord get blood supply?
Majorly by anterior spinal artery and
Anterior spinal artery is a branch of vertebral artery.
Vertebral.
Okay. Posterior spinal artery is a branch of. It's also a branch of vertebral artery. Posterior inferior cerebral artery. Pica. Okay. So these are the blood supplies. But anterior spinal artery supplies which all areas of spinal cord?
lateral anterior spinothalamic. Trans.
Except for the posterior column, all
everything
will
is
be
supplied by
the
anterior
anterior column.
Posterior column is supplied by posterior
Posterior
spinal
side.
artery. Okay.
So basically, if you take a spinal cord, there are mainly three tracks are there. One is the posterior spinal, then we have the corticospinal, and then spinal thalamic. So two will be going up, and one will be going down. Two will be going up.
Okay.
In that, if you think about this thing, dorsal column mainly it will be proprioception and this thing like fine touch will be in the posterior column,
Okay.
and other will be in the lateral spinothalamic.
Proprioception means vibration,
Vibration, joint positioning, and all that. So, in order to differentiate a patient, we can specifically look for these things, and if it is intact, we can rule out the posterior involvement, and maybe most probably it will be involving the anterior spinal artery. And in those kind of patients, the patient may be having involvement of both, like motor and sensory involvement also.
Okay. So you have three important syndromes: anterior cord syndrome, posterior cord syndrome, central cord syndrome. What is central cord syndrome?
Usually seen in old age and all that. Basically, the involvement, the lesion.
Upper lesion will be more. Upper limb will be more involved.
Clinical presentation will
What
be
is
like
the common cause for central cord
like
syndrome?
hyperflexion or like flexion
Central
injuries.
cord syndrome.
So basically, the tumor or something. It
Tumor
will
or
be intramedullary tumor.
Syringomyelia.
So from inside out, it will grow. So it will depend upon the positioning of the tracts.
Okay.
So it will be central CTLS, cervical, thoracic, lumbar,
So
sacral.
you call it as suspended anesthesia. So the fibers are involved in a fashion cervical, thoracic,
lumbar, spine.
because they cross every section. So that it's
So the involvement will be spreading from the middle to the exterior.
So cervical and thoracic involvement more than the lumbar and.
So always the weakness will be more in
but the sensation will be lost in the
upper limb.
cape-like sensory loss. Okay. Okay. What happens to the bladder?
Bladder
involvement will be
won't be there. It will be last involved.
Okay.
so it will be
Then,
Uh,
but comparing with the extramedullary compression, intramedullary compression will have early bladder involvement because bladder fibers are the medial part of the spinal cord, so they involve faster than an extramedullary compression. Okay, bladder involvement can be there, but it takes some time. But comparing to an external compression like your what is it? Cervical spondylosis, it takes more time because bladder fibers are the medial part of the spinal cord. Okay.
so this patient, since he was not improving, we went with a repeat scan after a few days, and this time it was showing some hyperintense lesions from the dorsal cord to the cornus with diffuse restriction. And also aortogram was also done, but to rule out any extension of the previous abdominal aortic aneurysm, but it was showing only an atheromatous plaque. But there was a small a thrombi was noted in the aortic spinal artery. A small thrombi was seen, but actually this couldn't be directly related, like associated with this extensive weakness. So it was considered as one of the DDs of the which may have caused these symptoms. But considering the rare possibility, the patient was planned for plasmapheresis also. But initially, even though it was planned, but again they went ahead with only conservative management, as per Bishop's bystander. So we went ahead with PMR and physical rehabilitation is initiated. So currently he's undergoing his physical rehabilitation. So on initial arrival, considering this patient, we had some DDs like one primary. This thing was actually a secondary mets because of his previous malignancy, and then we ruled out any viral infections like any HIV, herpes simplex, Epstein-Barr and all, which we ruled out. And also rarely the patient can also have multiple sclerosis or maybe even neuromyelitis optica, even though it's not very common in India, was considered DD, which again ruled out. All came to be negative. There's no history of any trauma or any histories. And also from the imaging we ruled out any direct spinal cord injuries also.
Trauma-induced spinal cord injuries are common in which areas?
lumbar.
Mainly in the C-spine and also
cervical. Because there is only free area which you can get as a
wherever the mobility is
more. Whereas in all other areas it is fixed. Okay. There are infiltrative lesions are very common, but this trauma-related severe trauma can produce lesion anywhere. Okay.
So where there's a transition of vertebra, like either the cervical to thoracic, or even in the D11 to L1, that area also there's high chance of
TB is common in which area?
thoracic.
Which thoracic segment?
T4,
T10.
T10.
Transverse myelitis is common in which area?
T4.
T4. Upper thoracic. Lower thoracic is tuberculosis. Lung infiltration and spreading to spine is common in T10. Okay, but abdomen, anywhere in the lower spine, anywhere it can happen. Okay.
So this patient's actually exact diagnosis is still unknown. But he initially clinically slightly improved with steroids and all that, but now he's currently undergoing physical medical rehabilitation.
Okay.
So suppose the patient is coming with primarily like a cervical lesion, we can think about nexus criteria in order to rule out any a need for injury evaluation. Suppose the patient is there is an absence of cervical tenderness or any focal deficit as such, and the patient is conscious oriented and there is not evidence of intoxication, and also any lack of distracting injury in a trauma patient, we can rule out with nexus criteria and all that. But this patient's involvement was more in the lower lumbar area, so we have to go for imaging to confirm our diagnosis. So especially coming from thoracic and lumbar and coming down, the best option will be going for an MRI or CT. CT will be to rule out any bony injury, and MRI will be to rule out any other injuries. It could be a nervous, spinal or other injuries.
Soft tissues by MRI, bone by CT.
So suppose a patient like transverse myelitis we are presenting to our ER, we have to think about different causes. One is an infective etiology or a local etiology like any malignancy or any soft tissue or other injuries. Then ischemic etiologies like any plaque or any thrombi. And then we have to think about nervous inflammatory conditions like multiple sclerosis. But as from ER, one best option we have is give a initial dose of high dose steroids we can give, which can actually reduce the cord edema and can actually have a good prognosis in the early stages. But in case of trauma, there are actually controversials regarding whether to give initial dose of high steroids or not. But there is one option we can give if there is any delay in definitive management in ED. So
even if there in trauma, if there is edematous lesion, steroids will be helpful.
So this patient currently actually is weakness is slightly improved and is still undergoing PMF for further management.
Is there anything?
So the patient underwent any surgery?
Yeah.
What was the surgery when he was undergoing the surgery?
Actually, patient had a history of CA stomach, and for which he underwent subtotal gastrectomy.
No. How long back?
About 5 years back.
5 years back, okay. So any recent spinal or epidural anesthesia can also be attributed in sometimes the incidences of the transverse myelitis. Okay. And suppose the patient you want to either go for a procedural sedation or an RSI. What are all the precautions and how important things you have to keep in mind?
Suppose a patient like this, actually there is a high chance of the patient can go for an ascending paralysis or an autonomic involvement could be there. So those kind of patients we have to think about using drugs which are more cardiac stable, etominet and all that.
Autonomic dysfunction has to be kept in mind.
One is autonomic dysfunction, sudden fluctuations in the blood pressure.
So continuous
either hypertension or hypertension and spinal shock. And the thing next.
So one thing is we have to keep in continuous hemodynamic monitoring, and the drugs which we choose should be more stable drugs like etominet or something.
Close monitoring and any respiratory paralysis. So sometimes either during the procedure or after the procedure also, immediately. And then regarding the muscle laxants.
Short acting is weaning off the patient will be difficult if it was a long acting muscle relaxant.
So instead of actually giving continuous infusions, we can go for intermittent paralytic agents. And also if possible avoid.
Sensitive for non-depolarizing type of muscle laxants. So succinylcholine may produce in such cases hypertension. So better to avoid it. Okay. So the agents which will not produce either too high BP or too low.
So if possible, we can totally avoid paralytic agents in the further maintenance and all that, or we can do intermittent doses.
And the dosages of the muscle laxants you can reduce it.
Okay. Anything else you want to tell?
Yeah, that's
Okay. Thank you.